Welcome back to Roadmap to Residency. This is Liver Disease Part 2, where we dive deep into cirrhosis complications. Today we are covering Ascites Management, spontaneous bacterial peritonitis, hepatic encephalopathy, and variceal bleeding prevention. The best part? We are doing this entirely through multiple choice questions with full answer explanations, just like you will see on the real exam. This is high-yield, test-focused content. For deep learning, use First Aid in UWorld. Before we start, like this video, subscribe and check out our expert tutors and residency advisors at roadmap2residency.com. Let us jump in. By the end of this video, you will master the approach to ascites, know exactly when and how to diagnose spontaneous bacterial peritonitis, understand hepatic encephalopathy treatment, and nail variceal bleeding questions. We are going through 5 multiple choice questions with detailed rationales for every answer choice. This is exactly how boards test these topics. Before we hit the questions, let us review the framework. Cirrhosis complications fall into 2 categories. First, portal hypertension effects. Ascites from increased hydrostatic pressure, varices from collateral vessel formation, splenomegaly causing low platelets, and hepatorenal syndrome from abnormal blood flow. Second, synthetic dysfunction. Coagulopathy from decreased clotting factors, hepatic encephalopathy from ammonia buildup, low albumin causing edema, and hypoglycemia in severe cases. Every question will test one of these pathways. Here are your buzzwords. For spontaneous bacterial peritonitis, cirrhosis plus ascites plus fever or abdominal pain plus acidic fluid neutrophils greater than 250. For hepatic encephalopathy, confusion plus asterixis plus elevated ammonia plus a precipitant-like infection, bleeding, or sedatives. For variceal hemorrhage, cirrhosis plus massive upper gastrointestinal bleeding plus hypertension. Memorize these patterns. Question 1. 55-year-old man with alcoholic cirrhosis, new abdominal distension, shifting dullness, bilateral leg edema, afebrile. What is the first step? Read the choices carefully. A is start diuretics. B is get a computed tomography scan. C is diagnostic paracentesis. D is sodium restriction. E is schedule a transjugular intrahepatic portosystemic shunt. Take a moment to think about this before I reveal the answer. The correct answer is C, diagnostic paracentesis. Here is why. The absolute rule on boards is that all new or worsening ascites requires diagnostic paracentesis before starting any treatment. You must rule out spontaneous bacterial peritonitis and confirm the cause with a serum ascites albumin gradient. Now let us go through why every other answer is wrong. A is wrong because you never start diuretics without first confirming the diagnosis and ruling out infection. B is wrong because computed tomography is unnecessary. Paracentesis gives you the answer directly. D is wrong because sodium restriction is part of treatment, but diagnosis must come first. E is wrong because transjugular intrahepatic portosystemic shunt is reserved for refractory ascites that fails medical therapy. Remember, paracentesis first, always. Question 2. 60-year-old woman with cirrhosis and known ascites presents with fever and diffuse abdominal pain. Paracentesis shows 2,000 white blood cells with 80% neutrophils. Gram stain is negative. What is the treatment? A is wait for culture results. B is ceftriaxone plus intravenous albumin. C is metronidazole alone. D is oral ciprofloxacin. E is emergent surgery. What would you choose? The correct answer is B, ceftriaxone plus intravenous albumin. Let us break this down. First, calculate the absolute neutrophil count. 2,000 times 80% equals 1,600. That is way above the 250 threshold, so this is spontaneous bacterial peritonitis. Treatment is empiric third-generation cephalosporin plus albumin. The albumin is critical because it prevents hepatorenal syndrome and reduces mortality. Now the wrong answers. A is wrong because waiting for cultures can be fatal. Spontaneous bacterial peritonitis is diagnosed by cell count, not culture. C is wrong because metronidazole does not cover the gram-negative bacteria causing spontaneous bacterial peritonitis. D is wrong because oral fluoroquinolones are for prophylaxis, not active treatment. E is wrong because spontaneous bacterial peritonitis is a medical emergency, not surgical. Surgery is for secondary peritonitis when there is bowel perforation. Here are the spontaneous bacterial peritonitis pearls you must know. For diagnosis, the magic number is acidic fluid neutrophils greater than or equal to 250. Gram stain is often negative. Culture typically grows a single organism. If you see multiple organisms or very high protein, suspect secondary peritonitis from perforation and get imaging. For prophylaxis, boards love testing this. Primary prophylaxis is indicated for any cirrhotic with gastrointestinal bleeding or acidic fluid protein less than 1.5. Secondary prophylaxis is lifelong after any episode of spontaneous bacterial peritonitis. Use norfloxacin or trimethoprim sulfamethoxazole daily. Question 3. 62-year-old man with hepatitis C cirrhosis presents with confusion and sleep-wake reversal over 3 days. He has asterixes on exam and was recently started on oxycodone for back pain. Ammonia is elevated. What is the initial treatment? A is discontinue oxycodone and observe. B is start lactulose. C is start rifaximin. D is urgent transplant evaluation. E is give flumazenil. Think about what the first-line therapy is for hepatic encephalopathy. The correct answer is B, start lactulose. Lactulose is always first line for hepatic encephalopathy. It works by acidifying the colon, which traps ammonia as ammonium and prevents absorption. It also causes osmotic diarrhea to excrete the ammonia. Titrate to 2 to 3 bowel movements per day. You should also discontinue the opioid trigger, but lactulose is the active treatment. Now the wrong answers. A is wrong because observation alone is not enough. You must actively treat with lactulose. C is wrong because rifaximin is add-on therapy for patients with recurrent hepatic encephalopathy who are already on lactulose. It is not first line. D is wrong because transplant is not the acute management for a reversible episode. E is wrong because flumazenil reverses benzodiazepines, not opioids, and is not standard hepatic encephalopathy treatment. Question 4. 58-year-old man with newly diagnosed cirrhosis has screening endoscopy showing large esophageal varices with red whale signs. He has never bled. What is the management? A is no treatment until he bleeds. B is propranolol only. C is endoscopic variceal ligation only. D is propranolol or endoscopic variceal ligation. E is proton pump inhibitor. This is testing primary prophylaxis for varices. The correct answer is D, propranolol or endoscopic variceal ligation. This is primary prophylaxis. Large varices or varices with red whale signs have high bleeding risk and require intervention before the first bleed. Either non-selective beta blockers like propranolol or Nadolol or endoscopic band ligation is acceptable. Both reduce first bleeding episodes by about 50%. The key word in the answer is OR, meaning either option is correct. Wrong answers. A is dangerous because waiting for bleeding with high-risk varices is unacceptable. Variceal hemorrhage has high mortality. B and C alone are wrong because the question asks for most appropriate answer, which acknowledges both are valid options. E is wrong because proton pump inhibitors do not prevent variceal bleeding. They are not part of prophylaxis. Final question. 52-year-old man with cirrhosis presents with massive hematemesis. Blood pressure 80/50, heart rate 130. He is confused and pale. After starting resuscitation, which medication is the immediate priority? A is propranolol. B is proton pump inhibitor. C is octreotide. D is lactulose. E is norfloxacin. This is acute variceal hemorrhage management. The correct answer is C, octreotide. In acute variceal bleeding, octreotide or terlipressin is the priority medication. These are splanchnic vasoconstrictors that reduce portal pressure and blood flow to the varices. Start immediately along with resuscitation. Continue for 3 to 5 days. Urgent endoscopy for band ligation should happen within 12 hours. Wrong answers. A is wrong because propranolol is for prophylaxis, and beta blockers can worsen hypertension in an actively bleeding patient. B is wrong because proton pump inhibitors help after endoscopic therapy, but do not stop variceal bleeding. D is wrong because lactulose treats hepatic encephalopathy, not bleeding. E is tricky because antibiotics like ceftriaxone are indicated in variceal bleeding to prevent spontaneous bacterial peritonitis, but octreotide to stop the bleeding takes priority. And that wraps up Liver Disease Part 2. You now know how to approach ascites, spontaneous bacterial peritonitis, hepatic encephalopathy, and variceal bleeding on boards. Remember to like and subscribe, and visit roadmaptoresidency.com for personalized tutoring and residency advising. Good luck on your exams.